It's a pleasure to talk to you today. The webinar we're going to be talking about is for artificial intelligence in healthcare. My name is Steve Filler. I'm a partner director out of the Chicago office for BCG. I've been lucky to work with BCG for the last 3.5 years. Prior to that, I've led large-scale IT transformations for hospitals and health systems around the world, most notably at places like Stanford, Partners, and Kaiser. I was a CIO at JPS Health Network in Fort Worth, Texas. It's a large academic medical center in the US, and was a chief operating officer at Practice Fusion. Prior to its acquisition by Allscripts, it was the 4th largest EMR company in the US. As much as possible, we would love this to be an interactive dialogue. There's a chat box on the bottom right. Please feel free to ask any questions you would like. Everybody happens to be on mute, but I will be stopping the presentation and communicating as much as possible. So please do feel free to ask questions in the chat. We have about an hour, and I'd like this to be, like I said, interactive, fun, a nice dialogue. I'm going to leave 15 minutes at least at the end, if not more, for questions and answers. The agenda for today is fourfold. We're going to talk about what is artificial intelligence. Let's everybody have a simple baseline of understanding of what we're talking about, how artificial intelligence applies to healthcare, dealing with COVID-19, the potential impact of COVID-19 and AI's role in providing healthcare in the new normal. And then ultimately we'll finish with the future of AI. So what is artificial intelligence, or AI? AI describes a range of techniques that allow computers to perform tasks typically thought to require human reasoning and problem-solving skills. The bulk of the conversation today is think human processing by computers. In the healthcare world, there's a lot of unstructured data: the patient's EMR, the lab information systems, the radiology information systems, point-of-care testing, wearables, thousands of different disparate devices, often that don't talk to each other. And what AI is going to be able to do is bring together through an intelligent algorithm, teach itself and learn and structure that information into a complete structured data that's going to be continuously improved over time. The initial hypothesis, the initial thought process will only be refined and improved as time goes on through testing, retesting, and revalidation. It's a continual learning process, similar to the human mind. At the end of the day, the idea is to provide smart results. However, how is it different than the regular computer programs? In a traditional computer program, think Microsoft Excel. It is deductive. It is 1 + 1 = 2. It's a static answer. It is a singular answer. It is something that is true for a particular point in time. Artificial intelligence systems are inductive. They're iterative. They go through a lot of self-learning and through process and re-engineering and a lot of training. And it really results in probabilistic answers rather than an absolute. And because as the time goes on and the refinements occur, it keeps learning, teaching itself. For those of you who remember the movie War Games, it's a good, towards the end of the movie, there's the computer teaches itself how to play tic-tac. End of it, after going through thousands and thousands of games, it realizes it's a stupid child's game, and they'd rather play chess, which involves more thinking. That indication of how the computer taught itself and reiterated and relearned and continuously learned is a good indication of what AI is really all about. It is something that will continuously improve, but again, it's not ever an absolute. So let's talk about how it works with simple imagery. How does a computer know the image on the screen is actually a cat? Well, before you even start analyzing that particular image, you will previously train the computer on thousands of images of cats, dogs, lizards, and birds, and really try to educate the computer to say, here's what a typical cat looks like, here's what a typical bird looks like. And then you get the individual image you want to assess. That image is then broken down into small pixels, and those pixels are then converted into individualized data. The computer will then assess the data points against its neural network, against its previously trained information, and it will then provide a probabilistic answer of mostly this is a cat, 97% chance this is a cat. What gets interesting is when things like a hairless cat comes up to be assessed. A hairless cat technically is a cat, but the computer, based on its initial education, might think of it as a rat, as an example. But through constant training and constant iterations, instead of going from a 50-50 response to the hairless cat is either a cat or a rat, through ongoing training based on facial recognition, through the body style, et cetera, it realizes over time that 50% of where it's a cat or a rat goes to 90% cat, 10% rat, as an example. It's continuously learning, continuously modifying, continuously training itself. How does AI apply to today's standards and devices that we use on a regular basis? People have, a lot of the ones on the right, people use in their homes today. There's a bunch of building blocks and there's a bunch of components that actually work to drive today's standard products. Through image recognition, text processing, speech generation, image generation, we have what basically are the foundational components to AI. If you look at Amazon Echo or Alexa, it uses personal speech to guide it and teach it as to what the user's behavior is. For my case, I'll say, Alexa, play me my music. My music happens to be yacht rock or smooth jazz, but it knows never to play rap or heavy metal because I have a disdain for that type of music. Others might be the exact opposite. And Amazon learns my type of music over time through repetition and relearning. Netflix, because my family's been quarantined like many other families around the world, we have been watching a disproportionate number of cartoons lately. And my young girls are loving the cartoons that we're watching. And so in my Netflix recommendations, it's going to have the next 27 movies that we're most likely going to be watching will be yet more cartoons. And because of that, Netflix has learned over time, based on our recent behaviors, which movies to ultimately recommend. Self-driving cars is another example, one that I personally would love to see more of. You get each of those cars learn from each other. There's a network of cars, and they learn how to avoid obstacles, the rules of the road, learning to drive through various obstacles, like when I was in Chennai, monkeys jumping on the car. And the self-driving cars will learn how do you mitigate those type of scenarios, versus in the US, you have people just running across the streets, as an example. Any questions before I move on? Otherwise, we're going to dive right into how AI actually applies to healthcare today. Nope. Okay. Now is finally, we are at the precipice of why AI makes the most sense to actually get a good foothold in healthcare today. Even before COVID started, there was a pressure with healthcare costs, improve quality outcomes. The rising costs, the lack of symmetry in terms of care standards, the high consumer expectations, the consumerism of healthcare today, compound that with the fact that we finally have a robust amount of patient-specific data. EMRs are becoming a lot more pervasive. They're providing a lot more patient-centric data and patient-available data. Combine that with the fact that genomic data is finally becoming cheap and usable and effective. And then combine that with the fact that we have home-based monitoring devices and wearables, things like Fitbit, Garmin, Jawbone, and then home-based components like capsules technology, which enables you to get on a scale or take your blood pressure or do your diabetic blood sugar analysis, and that information gets uploaded to the patient's EMR. And so those type of components, plus the pacemakers and the implantable devices, are really creating a larger view of what the patient's true systems are, true vitals are, true clinical diagnoses are, and you're getting that harmonistic and large amounts of patient-specific data. But a lot of that data now is becoming discrete. When it's not discrete, that's when technology like Nuance's Dragon system comes into effect, where you have the voice recognition and the natural language processing components to really take in some of that arbitrary data and really make it become discrete, so it's actionable and intelligent information that can be analyzed. And you use that with the increased computation and processing capabilities that we have today versus even a couple of years ago. And once you put all three of those together, it really is the right time to start integrating and utilizing how AI can really benefit the healthcare ecosystems across the world. There are three primary areas in which AI can really drive and has proven to actually start driving to drive a lot of the improvements. The first is in remote prevention and care. I'm not going to read all the things on the slide. You guys can do that faster than I can speak, but I'm going to talk about real examples about each of the three. And in the following two, the latter two, we're going to actually get into some tangible examples. But on the first one, where computers can be virtual assistants, I'm going to give you a real example of one. It's Facebook. People don't actually realize that there's AI built into Facebook for healthcare purposes. But Facebook is often utilized as the last application people see at night, the first application people see during the day. And then based on that, with some degree of range of significant evaluation, you can get an assessment of how much sleep is that person getting every single night. If the sleep is getting reduced, and combine that with the person actually then having posts on their Facebook pages that are morbid, sad, depressed, suicidal thoughts, what have you, Facebook is actually trained to send those people, information for behavioral care therapies. So, hey, you may want to talk to XYZ, and the ads that they're going to see are actually going to be geared to getting them some support. And it's a way in which Facebook is actually helping to minimize suicides. In the diagnostic support, we're going to talk about two pretty exciting examples. There's the Google's diabetic retinopathy example, and then one that I personally was involved with at MIT and MGH on breast cancer assessments and risk stratification for breast cancer patients. And then we're going to talk about another one, really personalized under the treatment pathways and support, personalized medicine for patients through a company called NAMS Health. We're going to dive into all those examples at the very end. So in terms of one of the pathways that we were just talking about is Google is developing deep learning to diagnose with diabetic retinopathy. As many of you are well aware, only 6 out of 72 million people throughout India with diabetes are actually screened for diabetic eye diseases. With Revenant eye hospitals, one of the things that they're doing is the patients are having images assessed by the staff there. But those images are then uploaded to a screening algorithm. Through automated machine learning, the patients are then given the screening results delivered not just to the clinicians at the eye hospitals, but also to the primary care physicians, and really trying to significantly increase the propensity of patients who are diabetic to have avoidable treatments and identification of possible retinopathy disorders so that they can be treated sooner and prevent blindness. Another example of one that I was actually personally working with was there was a combination of the MIT researchers with MGH. I came in from the MGH perspective. And Mass General is where Harvard's medical students go to train and do their residencies. 60,000 MGH patients have the opportunity to have their breast cancer mammograms screened. The idea was to take a look at very subtle patterns in the breast tissue for precursors to malignant tumors. What was interesting based on the research that was conducted is based on those subtle variances, 31% of those patients that were screened were actually put into the highest risk category that they potentially would have breast cancer 5 years out. And to have early detections, and in many of those cases were evaluated for the BRCA gene. But that 31% for using computer technology and the AI components is almost doubled what it was in traditional models, where only 18% of the patients were actually screened and identified in that highest risk category. So using the second level research and the automated testing, it really helped provide a secondary screening mechanism for some of those patients. And throughout this, I want all the physicians on this webinar to realize AI will never replace you. It will just support you. And this was one of those cases where AI was used to support the radiologist and the oncologist. In terms of precision medicine, NAMS Health is a great example of one in which that they are on creating targeted therapies for patients at the genomic level for oncology treatments. What they do is they take the patient's genomic markers along with that of the patient's tumor and really help to identify and create a personalized medicine and treatment plan and actually chemotherapy-based treatment that's tailored specific to each patient. What it's proven to do is increase patient outcomes, increase the treatment effectiveness and efficacy, but also do it frankly in a lower cost option, because the treatment is typically done the right time, the first time, the right way, and it drives significant patient improvement. And so by taking a look at not just how to treat patients holistically with oncology-based diseases, but really treat them in a targeted, precise way that's unique to each patient, the opportunity for remedy and basically removal of each of the tumors and targeting those tumors for removal is significantly higher. Now let's move on to the potential impact of COVID-19. Unfortunately, every country basically has been impacted by COVID-19. One of the things that we are going to be looking at, there's a couple questions that are coming in. I am not an expert. I am not a clinician, so I should have said that up front. I am coming from the IT perspective. So some of the true clinical questions, I apologize. I'm unable to answer some of those, including how plasma therapy will play a role against COVID-19 and certain tests. I don't want to misspeak or allude to the fact that I am a clinician. I am not. I was a CIO and came at it from the IT perspective. So my apologies for not being clear about that up front. In terms of the COVID-19, the pandemic has spread pretty much to every country worldwide. Fortunately, there's a leveling of the curve, and we're moving from the flattening period to the fight period in many countries. Unfortunately, in India and in the US, we're having difficulty in both places, really flattening some parts of that curve. But the doubling has slowed down in many cases. The number of days of doubling the cases over the last 2 weeks has basically also doubled in the last 2 weeks. The number of recoveries has doubled, and the number of countries with active cases has really slowed down from 2 weeks ago it was 59, now it's only 66. That still is a lot, but as we look at the next slide, the curves are really starting to flatten on the right side of the screen, are really starting to flatten for most countries. Unfortunately, Singapore, Russia, and India still have pretty significant percentages of patients that are having COVID-19. The US has a disproportionate number of patients, but we are hopefully getting to the flattening of the curve, and with social distancing, with the right prevention methods, we'll keep that curve flattening and leveling out like people have seen in China. But let's just keep our fingers crossed. How AI will help to remedy some of the situations that COVID has caused, it's a real opportunity. It's a real driving factor, but it is not the singular solution. It is not a silver bullet, but it can bolster some of the capacity for some of these pieces. I'm going to be talking about a few of these. You guys, again, can read faster than I can talk. But near-term margin pressures. Doctors' offices and hospitals around the world are really feeling, doctors' offices are going to be driving a lot of, are feeling a lot of financial pressures. Algorithms can be used to help identify and eliminate variances in clinical and operational workflows. Any of those variances in the workflows creates waste. That waste basically results in additional cost. By mitigating and identifying the best practices, both for clinical and operational workflows, you're mitigating waste, therefore you're reducing cost. It's not going to be the end-all be-all savior for the margin pressures, but it's going to help drive significant improvements so that you as a clinician and the health systems you're working with can basically still provide superior level of care, but without the waste in the process. And in many cases, most clinicians that I've worked with over the years really love reducing the waste because it avoids some unnecessary steps that's wasting time for them. And if you think about waste as time is the most valuable asset people have. Let's drive out the waste, and using AI's algorithms, you can identify what some of those gaps are. Another one is improving patient access. AI is driven to significantly improve virtual assistants. making sure the patient is getting the right level of care at the right place at the right time. Using virtual triage through decision trees, you can actually help those patients identify, do I need to come into an urgent care setting? Do I need to go to the emergency room? Do I need to wait to the primary care physician? Or like in the last one, pushing towards alternative care models, can I do a telehealth visit with my patient? And by eliminating the needs for patients to be seen physically, you also mitigate some of that COVID-19 curve and really help flatten the curve by having some of those remote communications and remote conversations. But in order to really make that effective, you need remote triage. And many of the health systems that I'm working with are identifying through smartphones how the patients can self-identify some of the symptoms they're having to help them identify where they need to be seen. And can the patient be seen through telehealth, or do they need to be seen physically in an urgent care environment or emergent care environment? And so one of the things that by using AI to drive to the patients to triage them in the right effective way, you can really, again, somewhat help with the margin pressures, but really take some of the pressures off the patients themselves and make sure they're getting the right treatments in the right places. We're going to talk a little bit more about some of the other ones on the slide in a moment. Where is the future of AI going? This is a real example of how AI is going to be really streamlining and driving improvements in care in the very near future. So we've talked about how computers need to continuously learn. Well, computers are being shown thousands and thousands of angiograms, echoes, and ECGs, and identifying what is normal based on a physician's perspective and what is abnormal. And by taking a look at, for an individual patient, an angiogram, an echo, and an ECG combined, typically 3 different parts of data, the AI is actually being able to show the probabilistic risk factors for CVD for the patients. Again, this is not replacing a physician. This is going to drive towards probabilistic impacts so that it can be a second level referral for a cardiologist to say, when I'm sitting in front of my patient, what are the most likelihood probabilities that this patient's going to have a significant level of plaque, or assessment of their left ventricular function and where the chambers aren't functioning correctly, or they have some structural disease. And in driving the risk, you can take a look at not just today, but 3 years out from now, 5 years out from now, what is the probability that the patient in front of me is going to have some of these risk factors? So I can start mitigating those even before they show up in the echoes, or even before the patient has a heart attack or stroke. Let's start mitigating some of those potential impacts today. And using AI, you can identify where the patients are at the most risk factors based on looking several years out. And it is about to come to fruition even as we speak. We talked about precision medicine with Nant Health. We talked about remote patient monitoring earlier with Capsule and Fitbit and Jawbone and some of those other devices being able to be brought in with the pacemakers, what have you. Population health analytics in the time of COVID, you can't get any more serious than identifying the screening mechanisms and the screening requirements for COVID patients and identifying the population at risk or not. AI is driving a lot of the assessments. One of the things that I meant to mention earlier is Kaiser Permanente. It's a large health system in the US. It's a group health model where they take care of their insurance members, and there's around 44 million member patients that they have. They're using a company called Health Catalyst to drive the ability to proactively assess which patients are at highest risk for COVID, and then also using that same tool, identify what's the best course of treatment for the patients once they've been diagnosed, and to push that level of understanding and information out to their hospitals across 7 states in the US. And making sure that each of the patients that come in, or each of their members that come in, are receiving the best course of treatment in the most cost-effective way, but really to hopefully get the patients out of the hospitals and staying out of the hospital as much as possible. And they're using population health analytics to not only drive the best course of treatment, but prior to that, even identify which patients are at the most risk, so they can do some proactive communications with those patient members. Drug discovery and research is another one that is pretty interesting. Even before COVID, big pharma companies were having difficulty getting the right patients into their clinical trials. AI is being utilized today to not only identify which patients should work in conjunction with those clinical trials, but actually, based on the assessment, drive some of the results, drive some of the possibilities, and drive some of the preclinical trial assessments of what the expected outcomes are of the patients with various courses of treatments. And so AI is being utilized to not circumvent clinical trials, but really aid and assist and validate some of the clinical trial information, especially for those trials that have a very small number of potential participants. As I said before, and I want to keep stressing this, despite all the advancements in AI, all the treatment programs it can have, the assistance with diagnosis, the assistance with reducing cost and increasing access, at no time will AI ever replace the patient-physician interaction. There is no way it can completely be void of data issues. It will never be empathetic. It will never be free and of the ability to actually properly communicate with a patient or their families, and it will never substitute for your years of on-the-ground experience. That is just completely invaluable. And I don't care how smart a computer gets, that human-human interaction is never something that can be broken. And so please, I don't want you to ever think, based on this webinar, that the patient-physician interaction is ever going away, but AI can be utilized very effectively in providing a secondary level of education, communication, and probabilistic diagnoses to really assess, not just today, but in the future, a lot of where your patients are going. That said, even if it's great, and I personally am biased, but I do think there's a lot of significant benefits for AI, nothing will be working unless you create a very specific policy framework, both in terms of what is legally allowed, how to properly communicate, what is effective to actually analyze, and frankly, the reimbursement level for AI-based technologies. They're not free. In many cases, they're not cheap. And so you have to provide some level of understanding for the reimbursement. Otherwise, that simply doesn't work. And so without the policies in place for the legality of AI and the reimbursement for AI, you simply will have it's basically a non-starter. Everybody needs to have streamlined access to data. You need to have a harmonious way to get to the same level of information. Otherwise, it's disparate information is too broken. Many people, like I said, at the beginning, I led 42 Epic implementations. I led 42 separate Epic implementations. They're separate EMRs. Many cases, even if they're in the same cities, they don't talk to each other in an effective way. We need to be able to streamline and harmonize that data. There are data aggregators that do it pretty effectively, the Optums, the Truvums, the Truvens, IQVIAs of the world. They allow you to harmonize the data, but even still, it's clunky, it's kludgy information, doesn't work very well. And so I strongly see the need to streamline access to the data and really make it universally allowed. The EU is talking about making data available to a lot of places. Medicare and Medicaid in the US through CMS is doing the same. Having access to large geographies of people and the associated data will only improve AI. Equipping and training a skilled workforce. We have some of the smartest people in the world working in healthcare, but without them having knowledge of how to actually utilize AI, none of this is going to work. It's going to be met with too much resistance. People won't see it as a benefit; they'll see it as a crutch or even as a hindrance. By properly training the workforce, people can see how this can be a second level resource. And obviously, design standards have to be put in place so people can utilize it effectively and correctly. I just want to thank everybody. I see a bunch of questions coming up. I'm going to start changing the screen so that we can move this. Thank USV for putting this together. Thank BCG and from everybody. I appreciate it on behalf of BCG. Again, my name is Stephen Filler. It's truly a pleasure and an honor to have spoken with everybody. I am going to move the questions over so everybody can see them. Okay, here are some of the questions. What are those limitations using AI in the human body fit? Oops, I just lost them. Someone took it off of my screen. Oh, here we go. That's not, okay. What is the limitations of using AI in the human body physiology apart from, okay, whoever's moving this stuff, please stop, because I can't, it's hard to read if it keeps moving. Apart from some of the other aspects, for AI to work with human body interactions, it's going to require implantables. There are several implantable devices. I spoke with companies like DonJoy, who is working on actually creating an implantable device to provide information through knee replacements, hip replacements, etc., to provide information for how to actually impact it and how the patients are moving post hip replacements or knee replacements. We're still at the precipice of really interacting with the human physiology as part of this. It's gonna take some time to move in that model. There's a lot of regulatory components that have to take place. I have seen in many cases, like I just had shoulder surgery, and my doctor put sensors on the outside of my shoulder, but not implanted in my shoulder. There are components with pacemakers and defibrillators that are coming into place that's constantly sending messages back to make sure the patient's being treated the right way. They're starting information for human physiology testing. It's slow growth, it's slow process, but it's getting there, and it's working on it. AIs in diagnostics and pulmonary medicine. I used to be an administrator at UCSD, which is one of the leading pulmonary locations in the US. And I was working with some of the clinicians there to help identify deep vein thrombosis and some pulmonary embolism information for their patients using scan techniques for MRCT and echoes for some of the pulmonary patients, to not just look at what it's going to look like today, but how the deep vein thrombosis and pulmonary embolisms are going to be looked at and prevented and projected for 3 to 5 years out. Is that a great example of pulmonary medicine? Possibly. It's still in the neophyte stage of deployment, because like I said, it takes time to train the computers for the tens of thousands of messages and images that have been scanned. And unfortunately for the pulmonary embolisms cases that we were seeing at UCSD, while it was nationally a very prominent location, we still only had a few thousand cases a year. And so to get to the level of computation that you need to really do some of those assessments, you need even more information. And so they were working with their colleagues from around the world to collect more information. It's still in the early stage for pulmonary medicine. What is the usage of AI in the day-to-day for pathology lab work? So great question. BD has a program out today through a company called Cato that is actually a product, I should say, called Cato, that is actually working on not only expediting the lab processing for pathology, so that you're not having to wait for 3 weeks, 4 weeks, 6 weeks for some pathology tests, but to take the early stages of the pathology diagnosis and those early petri dishes, and forgive me, I'm not a clinician, this is my understanding of what's going on, to identify how they can actually project where the pathology is going to go, so the treatment's going to be started sooner for some of those patients. It takes the pretty significant BD device, the Cato device, to be integrated into the specimen collection process and the pathology testing process. But combining the device, which speeds the incubation period, and the AI piece of the computers doing the assessment on the pathology, it actually expedites a lot of the testing. And so you can have a significant reduction in the time delivery. Let's see the next question. AI is expected to become increasingly important in healthcare. Will it ultimately replace human physicians? Absolutely not. It never will. Some are claiming it will not replace but complement human beings, and I completely agree with that. As conventional physicians, how should we prepare ourselves now? Prepare ourselves now to embrace the second level of communication. Embrace it with the idea that AI will always be a resource, like a medical journal, or um, or a colleague that you can go to say, hey, I have this complex case. How do you think, how should I think about this? What are your thoughts about it? AI should be um, AI should be the requester. It should be the reference. It should be a secondary component. It should be a secondary source of information, but it will absolutely never replace the patient-physician interaction. That human connection is too important. The ability to communicate is too important. And while AI is a great tool, it is not a physician. And so I also don't believe any government will ever authorize a computer to legally replace a physician. And I don't care how smart ultimately the computers get to, it is going to be a driving factor for to always have that patient-physician interaction. And I firmly believe that 50 years from now, when I'm long in the ground, we will still never have a date that physicians are replaced by computers ever. Common things to be considered in heart care. Well, I mentioned a couple. I think the more studies that are analyzed, the more echoes that are evaluated, the more ECGs that are evaluated, the more ways that you can identify arterial vein thrombosis and some of the other pulmonary disorders as well as cardiac disorders and combine them together. It's the ability to really not only project, to properly diagnose and assist in the diagnosis of the patients, but also project where people are going to have heart conditions and preventative components for strokes and heart attacks 3 to 5 years out, so people can start mitigating and really improving their exercise and diets, and even taking some medications ahead of the time, and to avoid some of those catastrophic conditions that people are going to have. Okay, let me get through. What is the future of AI developing in countries like India? Significant. I will tell you that in my former life, before I joined BCG, I was at a company called Accenture. I had 1,500 colleagues in Bangalore and Chennai working specifically on this. And a lot of the developers are in India today. A lot of the personnel who are knowledgeable and capable of driving the decisions are there today. And I foresee India being a driving force for AI for healthcare for decades to come. The people in the country are frankly too smart on the topic, too knowledgeable about the topic, and because of the size of your population, you can actually have proven results so much faster than so many other G7 countries. So yes, I think India is going to be a driving factor. How's the medical legal part of it going to be dealt with? That's a tremendous question. I wrote a textbook on this, or parts of a textbook on this earlier. It's going to be regional specific, and it's going to be very difficult. You find throughout the world, there's various levels of what is legally allowed for. So like in Sweden, you can have doctor-assisted suicide, but in places like the US and parts of South America, that is absolutely forbidden. AI is going to be the same way. It's going to be country specific or even regionally specific. It's going to be difficult. As long as a physician and patient have primary interaction and AI is just a secondary resource, you're going to have less of the legal implications of it. The piece that concerns me the most is if it becomes a standard of care, and that always is the kind of the standard of which people evaluate all medical legal questions. If it becomes a standard level of care to get that secondary diagnosis and people avoid it because they're risk avoidance to using new technology, what that's going to mean. To date, we haven't seen a case like that yet. I don't foresee one in the near future because it hasn't yet been the clinical standard in any modality, any physician practice. But in the future, it could be, and that's where the medical legal questions are really going to come into part of it. Let's see. there's always a chance a healthcare manager goes to non-medical persons. What's your take on the ethical part of it? I think I've addressed this quite a bit. I also started my career as an ethicist. I would never venture to say that it's ever allowed to, that the patient-physician interaction can ever be ultimately removed. I think they're parts of the triage process or identifying that they should go to the right course of treatment. So the actual treatment that's delivered, the treatment that's projected, the treatment that is communicated is between two humans, a clinical staff member and the patient and or their family. Can AI beat the best human brains, or is it as good as its trainers only? AI has proven to beat human brains today. There was a video that we were going to show and it didn't work very well, but one of the leading researchers of AI for Google was coming out to say that its computers, Deep Brain, it's part of Google, it's one of the subsidiaries of Google, has already, through gaming technology, proven that it can beat the best humans. IBM Watson came out with the fact that its chessboard can beat Garry Kasparov and one of the leading chess players in the entire world. Computers, through constant iteration and learning and treatment and reiteration, retraining, will be better and smarter than humans. That's a fact. It will never be empathetic. And so the need to be able to synthesize and harmonize what the computer's telling you is going to be part of that training piece that I mentioned as one of the last slides. Being able to synthesize it and say, okay, we have all these different diagnoses, potential diagnoses, we have all these different potential outcomes. What is the most likelihood? What does it mean for my patient in front of me? That's where the training is going to have to come into place, but it will not necessarily replace who you are today. So Dr. Carthy, is there any scope for AI bots for clinical history eliciting for in doctor's office? It's a great question. I hope so, because obtaining clinical history is one of the most arduous tasks. Part of what a lot of companies are trying to identify are ways to synthesize the different patient records that an individual has from different locations. So I'll use my father as an example. He is a diabetic patient in his late 70s who has treatments in 2 different states in the US that do not speak to each other. I helped him work on a plan so that using a personal health record that he can actually communicate for his doctors in his 2 different states that he lives in, and be able to effectively communicate for those and be able to drive his clinical history so that the doctors in both physical locations whose systems just simply don't talk can actually obtain the requisite information. I'm in health IT. I had the ability to drive that for him and help him get to the right places so that he can help help explain it to his patient, to his doctors. It's still at the neophyte level to get there, but gosh, I would love it if you could get the clinical history, the social history, some of the precursor information, some of the environmental information, all collected prior to coming into the clinical visit, to really expedite the time in which the patient's sitting in front of you and being treating for you. Let's see. Is AI in COVID, how is AI helping with COVID vaccine research? It's really helping. So I was speaking with I went to the University of Minnesota and I was speaking with, which is a leading medical research hospital in the US. And I was speaking to the provost there, the head of the university the other day. And he was saying that we are going to be using the supercomputers, the Cray computers at the University of Minnesota to drive, the Cray computers at the University of Illinois, the University of Minnesota is climbing onto those, to drive COVID-based vaccine research through their different levels of public health analysis to really identify what are the right markers, the right components, the right factors into driving the testing mechanisms so that all around 65,000 people that go to school at the University of Minnesota and the 35 or 40,000 people that work there all could be not only tested, but then be at the front lines to actually receive the vaccine when it's ready. It is something that they are working on today. to identify through AI, bringing together all the disparate parts of information. One of those first slides I had, bringing all that information together to really identify what is the right course of treatment, and hopefully, crossing our fingers, identify what the potential vaccine is going to be, so we get it right the first time. And they're going to use that vaccine trial as part of the clinical trials assessment through AI to really analyze and assess where you're going with some of the potential outcomes of those vaccines before they're even given to animals and or humans, to make sure they're safe and have the right levels of clinical efficacy without any additional risk. And so AI is absolutely going to be paramount and is used right now. Multiple universities are doing that throughout the US, and I'm assuming throughout the world. Let's see. How can AI help in small single doctor managed clinic settings? That's a wonderful question. The nice thing about a lot of these solutions is the AI that's being built, the infrastructure that's being built on, it's being built on cloud infrastructure. And so the idea is, as you are looking in and working with your medical record systems, whether it's paper or computers, the websites that you can interact with and they can be integrated with will enable you to get access without spending a lot of money, but get access to the right levels of information. For AI to really work, it needs a lot of data to come in. For the data to come in, it's got to come in from a lot of different sources. Independent physicians throughout the world are, frankly, at the front lines of a lot of that information. And so for the AI companies, they recognize that fact, and those products are needing to have a partnership level with a lot of the individual physicians. You may be the only clinician to have an interaction with that particular patient. That particular patient may have a unique disease or disorder that needs to be analyzed to better the AI solution as a whole. That partnership is going to be paramount. There is a lot already in place, a lot of giving and taking of information that, hey, we'll give you the AI solution if you give us access to your data that's blinded for the patient's name and some of the personal health information. We don't want that information, but we just want to see their diagnostic information and their treatment protocols and treatment outcomes. That information is critically important. And so as those partnerships are taking place, are they rolling out fast enough? No. Are they rolling out at times? Yes. But what I would recommend is, as your individual physician, talk to the leading academic medical centers in your area, talk to the leading institutions in your area, and ask them, hey, if you have some new technology, what can I do to partnership with you? Not necessarily spend money to do it, but what can I do to partner with you? When I was at Stanford, as an example, we pushed out Epic, our EMR, to 650 independent physicians, and that became a precursor to some of the AI work that we were doing in cardiac studies along with Apple. And so those 650 independent physicians had no affiliation with Stanford. They may or may not have even referred to Stanford, but because they were in our community, we used them as a conduit for better information. Hospitals are doing this all over the world today. I would strongly recommend you talking with the larger health systems and the larger hospitals in your area. Let's see. How can artificial intelligence reach rural, remote areas of healthcare? Is it emergency treatment or chronic diseases? I just spoke about how it can reach rural healthcare. I will talk about another one that I participated with. It wasn't on the slides, but it was, again, when I was at UCSD, we used AI technology for stroke therapy. We had patients in, UCSD is based in San Diego in California. And once you get about 30, 40 miles or 50, 60 kilometers to the east of San Diego, it gets really rural really fast. The state to its immediate right or east is Arizona. The western part of Arizona is exceptionally rural. And we did an assessment where our neurologists and neurosurgeons would actually do stroke assessments on patients in those rural communities through telehealth and AI to identify the patients at the most risk for potential stroke cases. You wanted to be able to give them the treatments within the 3-hour period to prevent stroke symptoms. And so we used a combination of telehealth and AI to help identify those patients. And the AI piece of it was a screening mechanism to ensure that the right patients were immediately contacted to our, and based on certain mechanisms and symptoms that the patient was having, were triaged and immediately, if need be, assessed and communicated to our physicians to jump on the telemedicine to provide the local clinical staff the right course of treatment to basically prevent prevent the stroke scenarios. It's in use today. It works. Again, talk to some of the leading hospitals that you interact with. Okay, we've got time for one last question. I really appreciate it, everybody. In India, we have more mobiles than computers. Will AI move to the mobile? It already is. So a lot of those treatment programs that we talked about, a lot of the triage protocols, they're on the webs, they're on the phones today. AI is mobile. AI is being used to any phone that has access to either apps or the internet can get access to the AI technology that's being pushed out. It will be something that will be universally driven because, let's be honest, nobody wants to sit in front of a laptop to figure this information out. People want to be mobile. More and more healthcare is going mobile. And so, yes, the answer is, will it hit the mobile? It already is, and it will continue to be built that way. I just want to say thank you for everybody who participated. I see there was over 150 questions that were asked. It's a true pleasure to have spoken with you all today. I hope you got something out of this. I enjoyed it. And thank you and our partners for putting this together. USV, thank you very much for arranging this. It's a wrap. Thank you, everybody, and have a good night.